So hey everyone, Josh from SIBO Survivor, and today I'm very fortunate. I'm joined by Dr. William Chey. A little bio on Dr. Chey before we get into the discussion today. So Dr. Chey received his BA degree from the University of Pennsylvania and medical degree and training in internal medicine at Emory University School of Medicine. He went on to complete a fellowship in gastroenterology at the University of Michigan. And since completing this fellowship, Dr. Chey has remained at the University of Michigan, where he is a professor of medicine, director of the GI Physiology Laboratory, and co-director of the Michigan Bowel Control Program. Dr. Chey runs a very active clinical research group, which has received funding from federal and private sources. He's authored more than 200 manuscripts, reviews, and book chapters. He's a co-editor-in-chief of the American Journal of Gastroenterology, and so many other more accomplishments. So very fortunate to be able to sit down and talk with Dr. Chey and kind of just discuss IBS and how SIBO is connected and kind of clear up some confusion that a lot of patients and people have about IBS and how it's related to these other conditions. So awesome to have you, Dr. Chey. And I guess one question before we dive into the interview is kind of what's your focus now? Are you mainly research, or you spend half your time as a physician, or so what's your specialty now?
Yeah, so first of all, Josh, thanks for having me on,
Yeah.
and it's wonderful to talk with your audience. I spend about half my time doing clinical work, so I'm still a real doctor with an active clinical practice, and I spend about half my time doing a variety of other things, so research, mentoring the people in my research group, and also administration. You know, I run a couple of different programs here, including a multi-specialty group that takes care of patients with pelvic floor and pelvic floor disorders like fecal incontinence or chronic constipation, and also the nutrition and lifestyle program here.
Gotcha. That's awesome. So you kind of have your hands in a number of different gastroenterology functions.
Mm-hmm.
So I guess to start off in this interview, I want to focus on the definition of IBS, kind of how that's changed and where it's going. So I guess first of all, what is the definition of IBS, and how has this definition kind of evolved over time, and where do you see it heading?
Yeah. So first and foremost, I think it's important for everybody to realize that IBS is not a specific disease. It's really a symptom-based diagnosis that is predicated upon the presence of abdominal pain and altered bowel habits. And you're right, that definition has actually changed a bit over time. So for example, the criteria that we use to diagnose IBS are the Rome criteria. And the Rome criteria in its latest iteration has actually moved more towards abdominal pain and away a bit from abdominal discomfort. Now that may seem like a pretty subtle difference, but the reason we did that was because in some cultures, in some parts of the world, there are either no words or it's very difficult for people to articulate the concept of abdominal discomfort. And abdominal pain is a more universal theme. But the fact that the clinical phenotype, that is the range of symptoms that IBS patients can present with, is so diverse. Think about it: abdominal pain, diarrhea, constipation, or a mixture of both constipation and diarrhea, says a lot about the fact that the pathophysiology is also likely to be heterogeneous or diverse. In other words, the cause for symptoms in you, Josh, may be very different than the cause for symptoms in another patient that has really identical symptoms.
Yeah, definitely. And as a patient, and I know a lot of other patients out there, I think that's maybe one of the most frustrating things is it's so complicated, right? There can be numerous different causes, and everyone has a different situation. So you're saying it's gone away from abdominal pain, or?
No. We're very much focused on abdominal pain, and we're less focused on abdominal discomfort. But
Okay.
the good news is the vast majority of people that have abdominal discomfort also have abdominal pain. So
Yeah.
as it turns out, it doesn't have that much of an impact. I think from a pragmatic standpoint for your audience, IBS is abdominal pain, recurrent bouts of abdominal pain over
Yeah.
an extended period of time, 6 months at least, in association with altered bowel habits. So the main subgroups are actually defined by bowel habit. So IBS with diarrhea, IBS with constipation, or IBS with a mixture of constipation and diarrhea.
Gotcha. So, how do you think this definition will change going forward as we learn more about the condition?
That's a really interesting question because I think that you could certainly argue that we've probably taken symptoms as far as they can take us. In other words, we've gone through several iterations now as part of the Rome process to arrive at the Rome 4 definition for IBS, which is, again, based purely on symptoms. Now, we use some diagnostic testing, but the diagnostic testing that doctors do in clinical practice is almost all aimed at excluding organic diseases that can masquerade or mimic IBS. So we do testing to exclude celiac disease or inflammatory bowel disease or colon cancer, a whole range of different organic diseases that can cause symptoms very similar to IBS. I think moving forward, where we're going to go is developing biomarkers, that is diagnostic tests that help to rule in IBS. So symptoms aren't going anywhere. Symptoms are always going to be the backbone that leads to the algorithm that defines IBS. But I think we're going to be using symptoms plus biomarkers. Biomarkers to exclude other diseases, as we do right now, but also biomarkers to rule in IBS and give us insight into the specific cause of symptoms in an individual patient. The reason that's so important, I know we're going to talk about this more a little bit later in the interview, is because when we do that, when we have diagnostic tests that give us insight not only into the pathophysiology or cause of a patient's symptoms, we'll have a much better chance of choosing the right treatment for the right patient.
Gotcha. So that's exciting as a patient. So just to make sure I understand it correctly. So right now, IBS is pretty much a diagnosis of exclusion, right? You're excluding, let's say, Crohn's disease, celiac, making sure someone doesn't have those other conditions that can kind of mimic the symptoms. And then you're saying moving forward, we're hopefully going to head towards having specific diagnostic tests to actually help people show them what's causing their IBS symptoms, correct?
Exactly. And I think there's a lot of this is semantics. Like,
Yeah.
a lot of people say that IBS at the current time is a diagnosis of exclusion. And to some extent, that's correct in the sense that the testing that we do is to exclude other organic diseases. That being said, it's important to realize, though, that not everybody needs exhaustive diagnostic testing. In fact, most patients that present with characteristic IBS symptoms and no warning signs or alarm features,
Yeah.
that is, things like weight loss, bleeding, a family history of important organic diseases like celiac disease, colon cancer, inflammatory bowel disease. If you have characteristic symptoms and no warning signs or alarm features, it's reasonable at a primary care level to conclude that a person has IBS and to try simple treatments. I would actually argue that it probably is worthwhile to do a blood count, some serologies to exclude celiac disease, and tests to exclude inflammatory bowel disease like a fecal calprotectin or fecal lactoferrin. But really only limited tests. In other words, every patient doesn't need a colonoscopy. Every patient doesn't need an upper endoscopy. Every patient doesn't need an ultrasound or CT scan. So when we say diagnosis of exclusion, I just want to make sure that everybody understands that the exclusion part is quite limited to arrive at an accurate diagnosis of IBS, at least as a first step in treating patients.
Gotcha. So next is, can you kind of explain the relationship between IBS and SIBO? Because a lot of, Dr. Pimentel's team and a lot of other researchers and doctors now are, SIBO has kind of become the hot term, right? And I really think it's important even for people to understand the connection and not to kind of confuse them, right?
Yeah. Yeah, so this is obviously, we used to say back in the old days, it's the $1 million question. Now it's the $1 billion question, right? I mean, so this issue about the relationship between IBS and SIBO, there is clearly a relationship there. Now, the nature of the relationship remains to be completely defined. I think it's really important for people to understand that while there's an association, it doesn't necessarily prove cause and effect at the current time. So let me explain to you what I mean by that.
Yeah.
Part of the confusion around SIBO and IBS, there's no question that there's a higher likelihood of IBS patients having SIBO on the basis of breath testing, for example, compared to the general population. But the next step of the question is SIBO the chicken or the egg?
Yeah.
In other words, is it that SIBO causes the IBS symptoms, or is it that the underlying abnormalities in patients with IBS predispose to the development of SIBO?
Yeah.
The truth is, it's probably a bit of both, right?
Yeah.
So it's probably that patients with IBS may very well have abnormalities in motility and the gut immune system that predispose them to developing SIBO. And that SIBO leads to or exacerbates or worsens IBS symptoms. So it's probably both.
Yeah, gotcha.
But it's not as simple as people are making it out to be. I think is the key thing right now.
Yeah, definitely. And it's kind of tricky sometimes as a patient when you hear those two terms, just because. From my understanding, the way I kind of understand the research that's been out there is that, like you're saying, it could be the case, right, that food poisoning causes the nerve damage, which then SIBO is an after effect, right? So
yes, right.
So it's very tricky, and I think people need to keep in mind that. There are other issues going on, and SIBO could just be a state in their gut that happens because of those other issues, right?
That's right. It's a complicated issue. For some patients, clearly, identification of and treatment of SIBO is incredibly beneficial.
Yeah.
Obviously, there are many patients with IBS that don't have evidence of SIBO, at least on the basis of breath testing or even quantitative culture. And there are also patients that have evidence of SIBO where you treat it and their symptoms don't get better.
Yeah.
So I think the key thing just for everybody to recognize is it is a potential solution. It's worth going after, particularly in the diarrhea predominant or bloating predominant patients. But it's not the solution for everybody. Not all IBS is SIBO.
Yeah, gotcha. And so I guess one question coming off of that is let's say someone in my audience has tried antibacterial treatments or things to kind of treat SIBO, right? And they're not getting better, right? It's recurrent. And does that mean they should really kind of talk with their doctor or look into maybe that SIBO, just treating SIBO is probably maybe not the best solution for them? Or
yes, absolutely. Yeah. And let me just tell you, in the day and age of FDA approval for non-absorbable antibiotics like rifaximin, so in other words, people using it much more ubiquitously in clinical practice, the patients that I'm seeing more and more are exactly like the ones you're describing. Yeah. So it used to be, 5-7 years ago, that the patients I would see had not been tested and not been treated with antibiotic strategies. And a lot of them got better. But now the patients that I'm seeing have almost all gotten antibiotics and they have persistent symptoms. And so the question is, why is that the case? Is it persistent SIBO? Or is it that it's not SIBO related and it's some other mechanism that's responsible for symptoms that we would characterize as consistent with IBS? And, many times it's that latter that's the case.
Yeah, and that's very interesting and very good for my audience to understand because, if you're dealing with a chronic issue and you're trying like one thing, right, and it's recurring and you're treating it like that, it's probably a smart thing to focus on, okay, IBS, what are the underlying causes besides this, and what can we do to kind of improve that? So I guess the next thing to talk about here is what are the main underlying issues you see in IBS patients, maybe where SIBO isn't an issue, and then the patients where maybe you suspect that SIBO actually is an issue?
Yeah, that's a really great and important question that's really hard to answer.
Yeah.
In the sense that I think that we as doctors, as a medical community, because this literally every time I speak about this nationally or internationally, this question comes up.
Yeah.
And it would be great if we had a really defined answer. I can tell you that in the large phase 3 studies that were conducted with rifaximin, for example, we have tried to find clinical features, a phenotype that identifies patients that are more likely to get better with rifaximin, for example. Mm-hmm. We've also done that in our diet studies. And, what I can tell you is for rifaximin, patients that present with, most clinicians would say, experienced clinicians would say, focus on the patients that have a lot of bloating, flatulence, and diarrhea. But there are many patients that don't necessarily have that phenotype that also will get better with that strategy. I think for diet, interestingly, we found that pain and bloating are the symptoms that are most likely to improve with, like, for example, the low FODMAP diet.
Yeah.
It's pain and bloating are sort of the big ones that we tend to think about and go after, but they're not universal truths.
Gotcha. So I guess, are there, like, do you see that, like, motility is an issue for a lot of IBS patients, or, like, is there anything else that you see where, it could be kind of setting them up for this, the bloating, the pain, all that stuff, any other underlying issues?
Yeah, so I think if you think about, so back in the 1990s, when I was a GI fellow at Michigan, I was taught that IBS was a condition that was really largely attributed to abnormalities in motility, or the contractile activity of the GI tract, mm-hmm. visceral hypersensitivity, so this concept that IBS patients are hardwired differently so that they're more sensitive to a variety of different kinds of stimuli, whether you're talking about food or stress, medications, whatever, where they're more likely to develop symptoms with the same level of stimulation that an otherwise healthy person would receive and experience no symptoms. And then brain-gut interactions. So this idea about the communication between the brain and the GI tract, and which is why stress is such an important factor for many IBS patients.
Yeah.
I think as time has gone on, we've talked about many other things: alterations in permeability, activation of the gut immune system, dysbiosis or alterations in the microbiome, which is obviously relevant to bacterial overgrowth. And by the way, when you think about the microbiome, you could be talking about the location of where the bacterial contamination is occurring. So bacterial overgrowth is a great example of that, where you have contamination of the proximal small bowel, or contamination of the small bowel. That leads to premature fermentation and all the attendant consequences of that. But also remember that that other factors may also be relevant, although this is less well understood, and that is the composition of the communities. So not just the location, but what bacteria are in there, and also the quantity of bacteria that's in there. So there's a lot of variables to really put into the equation that we don't really have a great understanding of at the current time. I do think that a lot of the pathways, even these new pathways, permeability, immune activation, dysbiosis, can impact upon motility, which can lead to the development of symptoms, particularly in an individual with visceral hypersensitivity. So what I would just really emphasize is all of these potential factors that we have implicated as potentially important in the pathogenesis of IBS are likely intertwined.
Yeah.
They're not independent variables. They're codependent variables that interact to different degrees in different patients.
Yeah.
And that's what makes it so complex.
Yeah, that's what I was going to say. That's why it's such a complicated condition, because like you're saying, there's all these variables where one thing could have shifted the other, and then they kind of domino effect, right?
And that's why I think, by the way, Josh, that we really need to move towards, if we can, it's not going to be easy to do this, by the way. It sounds sort of conceptually very simple, but it's practically going to be very hard. But we need to move towards a model where we develop biomarkers that help us to understand how these different things are interplaying, and which of these factors are most important in an individual patient, so we can choose the right therapy for the right patient.
Gotcha. I guess on the microbiome topic, as what you've seen, the testing available now and the research that's going on, what do you see that we need to get a better picture of someone's bacterial flora, right? Because we're missing a lot right now. Is that correct?
Yeah. Well, yeah, because I think that, again, for example, a lot of the commercial tests that are out there, and obviously there are a lot of commercial tests out there now that claim to be able to provide a detailed microbiome analysis, and not just a microbiome analysis, but interpret what that means.
Yeah.
I'm skeptical about that given where the science is at the current time. I'm hopeful that we will be able to get to that point, but simply quantitating certain species, strains, families of bacteria probably isn't detailed enough to really give us insight into how they interact. In other words, the communities may be important, maybe just as important as the individual constituents, because the interaction, between the individuals that live in the neighborhood, may very well play a really important role to the degree of harmony that exists within the community, right? I mean, think about it just in terms of your own neighborhood. You may understand the individuals, but it's not necessarily how, the individuals as much as how they interact within the community that they live. So right now, the testing does not do that. The science is really not at a point where we're able to do that, but it's a very important factor that people need to take into consideration as people are trying to tell them that they can interpret the results of a microbiome analysis that simply tells them how much of each strain is present in their stool. The other thing is, remember that the stool microbiome, which is what we can measure right now, may or may not be the business end of where the microbiome is interacting with the host and leading to beneficial or detrimental things. People have been talking more and more about, for example, the mucosal microbiome compartment. The microbiome in your stool just represents the stuff that's in the lumen, and and a lot of it is dead. There's a whole different microbiome that's living on the lining of the GI tract that is actually directly interacting with the immune system and affecting things like permeability, neurotransmitters that are responsible for the function and sensation in the GI tract. And that, we know very little about that, and we can't really measure that at the current time.
Very, very interesting, and it's really good for people to understand. So, I mean, basically right now, the microbiome tests are kind of just, it's, right? There's no clinical relevance right now for those tests, right?
I agree. I think, put it this way, I think that it's really important for people to not try to overinterpret those results. I think you may very well be able to get some general information, like, for example, in regards to diversity. You can get some very general ideas about the health of your microbiome. But in terms of making specific recommendations, and for example, recommending that you need to increase this or decrease that, boy, I think you're not on solid ground in terms of the science at the current time.
Yeah, it makes sense. And it's just fascinating to me to kind of think about, like you were saying, the analogy of a community in your neighborhood, and even how complex that is with different people and different, the way they live their lives. One guy's a doctor, one guy builds homes. It's very complicated, the way the interaction, and it potentially could be something similar in your body.
I agree, and take extending this a little bit and just thinking about the next step. It may very well be that the metabolomics are more important than the actual microbiome analysis. Like, in other words, the metabolomics, the metabolic consequences of the interactions between the constituents of the microbiome may very well be, represent, again, that business end in terms of what's happening in the GI tract. People are just starting to look at metabolomics, things like volatile organic compounds. These things are very promising, very interesting, still very preliminary.
Gotcha. So back to kind of IBS a little bit here. So I'm curious about this. If any research you've done or anything that's been studied, so is there any reason why the abnormal sensation, the visceral hypersensitivity, and the motility what is kind of research shown that why IBS patients have those things?
So there's a lot of theories.
Yeah.
I think that a couple ones that are pretty well established at this point are early life trauma.
Okay.
So that can either be physical abuse, verbal abuse, sexual abuse, that leads to alterations in hardwiring of the nervous system that, while the nervous system is still developing during childhood, that seems to predispose to the development of IBS. Genetics, people have talked about a lot. I must say that there's been a lot more smoke there than fire, but increasingly there are descriptions of polymorphisms in the genome that predispose to the development of IBS. So there may very well be a inherited predisposition towards IBS based upon our genetics. And then the alterations in the microbiome, I think, are quite fascinating. You alluded to the group of patients, the well-defined group of patients with post-infection IBS.
Yeah.
This population of individuals that get an acute gastroenteritis. And by the way, it's, I think, a really important observation, interesting observation, is the fact that it doesn't have to be. See, I really am still a real doctor.
He's on call.
It doesn't have to be a bacterial gastroenteritis. It actually can be either a viral or parasitic gastroenteritis. Anything that revs up the immune system in the GI tract can lead to an increased likelihood of developing IBS. And so the idea there is that the infection activates the immune system, changes motility and visceral sensation, and when the infection's gone, those things are supposed to go back to normal.
Yeah.
But in 7 to 15% of individuals that develop a severe acute bacterial gastroenteritis, that it doesn't go back to normal.
Yeah.
It continues to be abnormal with development of abnormalities in motor function, contractile activity, and visceral sensation, predisposing to the development of IBS symptoms.
Very interesting. So I've heard a lot of percentages thrown around about how many patients are suspected to develop IBS from that. What would you say the percentage of post-infectious IBS, and that can also be considered SIBO, correct? That's kind of what most doctors are considering it. And like, what percentage-wise would you say of the IBS population?
Yeah, well, first I want to clarify. So it may or may not be SIBO.
Okay.
Certainly patients with post-infection IBS are likely to be predisposed to developing SIBO for all the reasons we've already discussed. But there are many patients in which they have a clear history of infection. You do a detailed diagnostic evaluation, including an evaluation for SIBO, and you don't find any evidence of SIBO. So my suspicion is that you are correct that there's probably an even higher likelihood of SIBO amongst individuals that have a post-infection etiology, but it's not a universal theme amongst those individuals. Yeah. That's the first thing just to recognize, because I don't want people to think that if they have a clear history of a gastroenteritis that preceded their illness, that they need to be retreated over and over again with antibiotics, for example. Yeah. They may or may not. Yeah. I worry that happens sometimes, and I also worry that may be creating more problems than it's solving. Because another interesting observation is that particularly kids that get repeated courses of antibiotics are more likely to go on to develop IBS. Yeah. So antibiotics are the solution for some, maybe the problem for others. Yeah. And it's just very important for people to understand that.
Yeah, it really is, because I think that's so important, that point, because just in the general, the term SIBO is kind of taken off, and a lot of people and even doctors that I've heard are focusing a lot on just antimicrobials, and I think it's so important to remember that there's other causes. There's people like you're saying, it's not the case that everyone just needs to take antibiotics.
I agree, and I think another really important theme again has to do with, remember that the evidence is for the non-absorbable antibiotic rifaximin. Now, it doesn't mean that other antibiotics aren't going to work. In fact, we know that for some patients, other antibiotics work. And in fact, there's studies, for example, from India with norfloxacin. But a really important thing just to remember is that rifaximin is non-absorbable. So it does not get into your bloodstream and will not affect bacteria in other parts of your body. That's important because, of course, what we're talking about is bacterial overgrowth or alterations in the microbiome within the GI tract. Yeah. And, obviously the lack of exposure of other bacteria in the body to the antibiotic is a good thing because, A, we're not trying to alter those bacteria, and B, we're not predisposing to the development of antimicrobial resistance down the road. When we're talking about using systemically absorbed antibiotics like amoxicillin, ciprofloxacin, et cetera, metronidazole, there's a very different type of concern there because, those antibiotics get into the bloodstream, will affect bacteria all over the body and are predisposing to the development of antimicrobial resistant bacteria that could cause pneumonia or skin infections, all sorts of different other issues. So in my mind, the best treatment and the most evidence-based treatment right now for SIBO and for IBS is rifaximin. And people should be careful, particularly about being treated recurrently with systemic antibiotics. Sometimes that's the only option related to cost, but where it is an option to use rifaximin, I think we're probably best off doing that, at least until we learn more.
Yeah. So would you say the bottom line is that really, if you're going to be using antibiotics, be careful because we don't know about the risks, right, that come with them and how they really affect our overall microbiome, right?
I couldn't have said it better. I think that's really sound advice. I think it's really important for people to understand that we're really at the start of this whole journey, not at the end. Yeah. The data that's shown that the microbiome plays an important role for some patients, i.e. That using things like probiotics, prebiotics, antibiotics, diet, which all affect gut microbiome, reinforces this concept that for some IBS patients, the microbiome is a key player in terms of pathogenesis and symptom experience. Yeah. But it's not the only solution. And we don't have the level of precision that I think we should all feel reassured by. So think about it. if you're talking about probiotics, antibiotics, or diet, the therapeutic gain over placebo is around 10 to optimistically 15%.
Yeah.
Yeah, that's statistically significantly different, but realize that's pretty close to, and maybe only a little bit better than around half of the patients getting better.
Yeah.
Which means that around half the patients aren't getting better.
Yeah.
So again, going back to that whole part, the discussion we had at the very beginning, right? We need to come up with better diagnostic tests, not better treatments, better diagnostic tests so that we can choose the right treatment for the right patient.
Yeah, and that way we know if someone, would actually benefit from the antibiotic treatment, right? Or else they need something else. Yeah.
Right.
So I guess just off of that point, so right now in IBS, as far as treatments go, what are kind of the categories that you treat? So there's the microbiome that some people may find helpful, those treatments that we kind of just talked about. What else do you do right now to help IBS patients?
Well, I think the big thing in my mind that's really changed in terms of IBS therapy, so there's some very effective medications which target specific pathways, opioid pathways, serotonin pathways, cholinergic pathways, brain-gut interactions like antidepressants. Mm-hmm. But I think that the key thing for patients to understand is, particularly those with moderate to severe symptoms, is that we're moving towards more of a holistic integrative model. Yeah. So not just medications, but also taking into consideration diet and lifestyle. So for example, obviously there's been a lot written and talked about with diet therapies. The one that's received the most attention right now is low FODMAP. Yeah. But also behavioral therapies are really coming to light as incredibly effective for many patients. By the way, not only patients who are, clearly depressed and anxious, but also patients in which stress is an important exacerbator or trigger for symptoms. Helping patients to recognize that, helping patients to have strategies to manage that can be life-changing. So it's not uncommon at all in my practice now. In my group, we have specific GI dietitians. We have specific GI behavioral therapists, in addition to the medical doctors as well as physician's assistants. And we work as a team to come up with the right solution for an individual patient. Sometimes that'll be more diet focused. Sometimes that'll be more behavior focused. Sometimes it'll be more medication focused. Sometimes it'll be all of the above. Yeah. But when you have moderate to severe symptoms that aren't getting better, with over-the-counter remedies, maybe the standard prescription medications, you really should be thinking about being seen in a center or a practice where they're taking a more holistic, integrative approach. Yeah,
definitely. Just because, kind of like we talked about, IBS is so complex, right? And all those things you talked about. And I've as an IBS patient, I've experienced the brain symptoms, it kind of all goes hand in hand, and it really is important for people out there, people watching this, that, if you're not getting better, you're having recurrent issues, you need to kind of work, like Dr. Chey is saying, more towards the holistic approach and kind of integrating all these different factors to find relief. Is that fair to say?
Yeah, I think that's totally fair to say, and maybe a good place for us to stop.
Yeah. All right. Well, thanks so much, Dr. Chey, for joining us, and good luck in your research and your practice. And I'm excited about the future of IBS treatment as well.
Me too. And I hope your patients are taking away a hopeful message, because I think the future for IBS patients is going to look a lot different than the past for IBS patients.
Yeah. I'm excited about just the diagnostic testing too, right? Getting more specific about why someone's having those issues and kind of dialing that in. So thanks so much for joining me, Doc.
Take care, Josh. We'll see you.
Bye.